evening. I'll just give the floor to Dr. Tsitsikas to just introduce himself.
My name is Dimitris Tsitsikas. I'm a consultant hematologist in London. I look after patients with sickle cell disease and thalassemia. But there's much more to say. I have quite an interest, obviously, in sickle cell disease. I look after patients with it. I have quite a bit of a academic interest, and I am very keen on research around sickle cell disease. And also, I'm quite interested in perceptions around sickle cell disease, both the perceptions of patients themselves, but also the perceptions that exist within the healthcare community and healthcare providers. And that's the topic I'm talking about today.
Oh, that's exciting. So how did you come? I know you sort of gave me a short biography, but again, for the sake of those people that didn't read, because sometimes people just look at pictures and they don't actually read. How did you get into medicine before you actually talk about your specialization in sickle cell?
Oh, good God. That's a very...
And how long ago was that?
That's ancient history.
Yeah.
I did want to go into medicine from a pretty young age, from when I was 13 or 14. I think if I had to pick one thing about what got me into medicine, is actually curiosity. It's that sense of how does the body work, and consequently what goes wrong with illness, and linking the normal function with what happens and it becomes abnormal and how you can fix it. But ultimately, if I were to describe it in one word, it would be curiosity. How does it work? How does the human body work? So that's what got me into medicine.
That's interesting. For me, the career I chose was business, and what got me into it, I think it's the dressing up. I wanted to be a banker because of how the bankers dressed.
Good point.
Not knowing that at some point I also be thinking about important things in life. Not that bankers, but I just thought I needed to learn more about my daughter's illness, so I had to change to go into sickle cell because of circumstances.
But sometimes we make very important decisions, not necessarily based on very important things. We just know something.
Yeah.
I think it was Oscar Wilde who said that for the important things, quite often you know the answer first, and then you work out the question. So it could be a bit like that.
Exactly.
And so that's what got me to medicine. And then when it comes to sickle cell thalassemia, especially sickle cell, it is a very exciting field for a doctor to look after, because it has so many layers, and also because it is a disease that we still don't know. And what I mean by that is we still don't know the natural history of the condition. We don't know what happens if you have sickle cell disease. We still don't know what happens when you're 40 and 50 and 60 and 70, because sadly, as you very well know, not so long ago, there was a lot of early mortality.
Yeah.
And it's now that our patients live longer and longer lives that we come to understand the late complications. So it's a disease that we are still mapping, and that is, from a medical perspective, for a healthcare professional, for a medical doctor, is actually very exciting. It is also a grossly under-researched area compared to other areas of medicine. So all these aspects are very appealing. And at the same time, there is the human factor, where the way it impacts people's lives. And that is not just at a purely medical level, but it affects their education, their employment, their everything. So it has so many aspects to it that makes it actually a very rewarding field to work on.
Yeah, I actually do also agree with you in terms of the complexity of this condition, because I think I was counting today. I'm doing something. I've had maybe over 60 or so people on this platform, and every person's journey is different. Even the subtypes of sickle cell SS, they're different.
Correct.
And you're right, there just needs to be more research to find out exactly why. I know it could be the percentage of the sickle cells, but still the complexity is just too much. But that's interesting to know. The other question that I actually wanted to find out So what made you decide to go into sickle cell, apart from the curiosity of going into medicine? Why sickle cell specifically?
Well, as I just said, I find sickle cell a very interesting disease, if you like, because it starts with a just simple mutation affecting just one molecule, and ends up with a condition that affects pretty much every organ and every system of your body, and that is quite unique. And as I said, there is that scientific, if you like, interest of still not knowing so much about sickle cell disease, and that is what actually attracts. Sometimes you don't want to go into something that is over researched and there's a lot of knowledge already. You want to go to, think of it as if you're buying a new house. You want to go into a house that you can actually add your own sort of style, if you like. It's not already done up for you. And sickle cell disease does have that. Sickle cell is still an area that is under research, is still an area that we don't know as much as we do for other things. And that is an attractive aspect.
So would you say you've got an investigative mind just to sort of know more information? Would that be right?
Yeah, it's part of the curiosity I was talking about, is being in an area where there are still things to be found out, and an area that we are finding out as time goes by. I suppose you do that everything you do, but sickle cell is a condition that we still don't know how it evolves, and now we are seeing it because our patients live longer, which is great, obviously, but we do start to see the complications of we didn't know 20 or 30 years ago, and how we treat that and how we change the management of sickle cell disease. Because, as I said, 20 or 30 years ago, the management of sickle cell disease was largely palliative in a way. Possibly saying 20 years is a bit too harsh, but 30 or 40 years ago, the management was largely palliative. Whereas in the 21st century, and I suppose that is part of my talk, our aim has to be, one, to make sure that our patients are comfortable, but also to make sure that our patients live 10 and 20 and 30 and 40 years from when we see them, and they are still in good health. And that is a different challenge, and that is a different aspect of the condition that is actually quite exciting.
Now, before you went into not so much medicine, before you actually not so much specializing in sickle cell, did you know anything about it? And did you just have it in mind that, once I do this, this is what I want to study? Like growing up, did you know anyone who had sickle cell and how it affected them?
I didn't. And actually, of course, I knew of sickle cell disease. I knew sickle cell disease as a medical doctor because when we train,
before medicine.
Oh no, I didn't know anyone about sickle cell disease. I had not thought of sickle cell disease at all, and I would go further to say that I didn't think of sickle cell disease while doing medicine until in my training as a hematologist, I did a job in sickle cell disease, and then it clicked. Sometimes you do something, you haven't thought of something, and then you see it and you recognize it and you say, yep, that's the one.
Yeah. Oh, but that's interesting. Now, in terms of your personal life, have you had to, do the test just to have the peace of mind? I'm sure that's how let me not assume, but that's one of the things that you do in terms of the people that you see. Do you encourage them to have their kids or their family tested? But as an individual, have you taken that step to find out your hemoglobinopathy status? Because I know from the Greek background, I've got friends, and one of our eldest people living with sickle cell disease in this country is Greek. Have you had to find out your own status, whether you've got thalassemia trait or sickle cell trait?
I think as a child I was tested and I was not a carrier. I think I was tested. I was not a carrier for either.
Mm-hmm. So would you want to reconfirm and just make sure that you don't? It's a trait. It might be potential passing it on.
I'm at that age that whatever I have passed quite some time ago.
Yeah.
So I'm not intending of passing on anything else, if you know what I mean. So
you'd encourage your family to get tested just to be sure.
Sure.
Yeah. Interesting. So thank you so much for that. And thanks everyone for joining us. So today you have a very, very, very good topic. And I said this from the beginning. My daughter lived with sickle cell disease for 10 years. And we only ever went to ED, I think, 2 times for pain. And you did say outright, is it just about pain? I did a Google search just temporarily to put in sickle cell disease and pain. I found over 2.3 million search on Google, just pain and sickle cell disease. So it is something that is really, really talked about. Sickle cell equals pain, but it's not all that I know.
It is very understandable that that is the case. It's just that it's important to have that perspective that is not just about that.
Yeah, yeah. Cool. So you can be able to share the screen, and then we'll go into some of the questions once you finish, and you can go for it now. Thank you so much.
Fine. Right. Let's see if I can actually do that. Don't trust my technical skills too much. Well, I don't.
So just on the bottom, there's a share screen, the green button right in the middle.
Yeah. Yep. Now, if I'm lucky, I'm going to click on the right button.
Yeah. Yes, we are loading.
So can you see it or?
Yes, it's up now. We can see it. Thank you.
Okay. Okay. So as I said, it's not a very doctory presentation. Don't expect graphs and figures and statistics. It's just to generate conversation. Right. So sickle cell disease. So when we think of sickle cell disease, the one thing we all know, and you don't have to be a patient or even a doctor, even if you stop 100 people on the street, if anyone knows of sickle cell disease, they will know at least one thing. And the one thing is pain. Pain is the most common symptom of our patients. And of course, it's the one that disrupts their lives the most. So pain we all know about. But at the same time, we know that sickle cell disease can affect any organ and system in your body, and it is associated with a large number of acute complications. Bear in mind that what I put there is just some. My purpose is not to make a teaching session about everything that happens with sickle cell disease. It's just to generate that discussion. So there are many more acute complications. I just put some. And equally, there is a large number of chronic complications. So we have pain and we have a large number of both acute and chronic complications that can be associated, and we can see in sickle cell. Now I'm going to take my crayons out and I'm going to start painting. So I'm going to make pain a nice blue. And then I'm going to think of complications that can be life-threatening or life-limiting, essentially shortening our life or being imminently life-threatening, but usually don't come with any pain at all. And I'm going to paint them red. So you can see quite a few, like sepsis and stroke or kidney disease and pulmonary hypertension. All these are life-threatening complications that usually are not associated with any pain. Then we have some complications that again are life-threatening, and these usually do come with pain. So I'm going to mix my blue and my red, and I'm going to make them purple, and you can see we have quite a few. So these are complications like the acute chest syndrome, which I'm sure we all know about, where even though pain is part of the complication, the most important thing is that it's a completely different thing and it can be life-threatening. Other than the life-threatening complications, we have complications that even though they're not life-threatening, they have the potential of leading to significant disability. And here I've been a bit lazy. I put visually both acute and chronic, but they are quite common. and they can cause severe disability, but usually are not associated with any pain. And equally, there can be chronic complications that are not life-threatening, but can lead to disability, and pain is part of them. So mixing yellow and blue gives us green, like priapism and leg ulcers. So just to recap the whole color coding system here. So we have our reds and our purples, and these are all life-threatening complications or potentially life-threatening complications. We have our yellows and our greens, where there is the potential of significant physical disability. And we're left with that blue, the blue of pain, pain on its own. And that is neither. So pain on its own, unless it's part of some of the other complications, is not life-threatening and does not lead to any physical disability. So what do we make of this image? What does it mean, having all those facts together? And of course, it doesn't mean the same to everyone. So present a computer with the last slide I showed you. And what the computer will do is use its intelligent software, will analyze the data, and will probably come up with something that looks like that, where all the life-threatening complications carry the most weight, and then it's the ones that can cause disability. And you can see that pain disappears at the far background as a little blue dot, simply because it doesn't kill, it doesn't cause disability. So it's, according to the computer, is of less importance. You show the same slide to a living, breathing human being, a patient, and no matter what the computer data showed, you will see that the perception for the human is completely different and looks more like that, where pain predominates and everything else, no matter how severe, is pushed in the periphery and marginalized. So two completely different perceptions of the same situation. And who's got it right? It's not very easy to give an answer to that, so I will give you a clue. This is Epicurus, and he's an ancient philosopher who more than 2,000 years ago, as he was pondering about the human condition, he came up with this definition for happiness. He defined happiness as the temporary escape from pain. And will you take a moment to think about that? So what he describes is that pain is really the steady state, is the normal sort of condition. And there are brief times that we escape pain, and that's when we are happy. And of course, Epicurus uses pain in a symbolic manner. So when he talks about pain, it can be anything. I am hungry and I'm happy when I get something to eat, or I have to work hard and I'm happy when I get some rest. So if we imagine that this steady state of pain reflects true physical pain as our patients experience, you can see how important it is to get relief from that, and how that is the first thing and the main thing our patients are after. So bearing that in mind, that computer model, even though it focuses on prolonging and saving life, it cannot work because it doesn't take into account the factor of happiness. So that cannot work. Talking of pain, pain is what most of our patients suffer quite frequently, and it's disrupting their lives. Pain is paralyzing, and you cannot think of the future when you're in pain. And you don't have to have sickle cell disease to know that. Any of us who has experienced severe pain for whatever reason, a bad toothache, we know that we cannot think of anything other than the pain when we are in pain. And that's why we need to treat pain very aggressively and very fast. And there is more to it. The experience of pain, because pain is an experience, it's not something we can quantify, it's not something we can touch or feel, it's an experience. So pain has got many layers. Of course, there is the acute pain, and then you have to go and give strong painkillers. But there are many other factors. It is a condition that has a huge psychological impact, and that has to be addressed. We know that more than 3/4 of our patients have severe sleeping disorders, and that has to be addressed. And there are so many other things as well. Financial, housing, employment, education, and all those things have to also be addressed if you are going to help someone's pain, because those painful crises are accentuated or triggered by any stressful conditions in their lives. And unless we address pain and we treat pain properly, we actually end up making it worse, because patients who don't feel their pain is adequately dealt with develop that fear of pain. They know that if they start having pain, it will not be treated appropriately, and they fear of it, and then the painful experience gets worse. And if all that was not enough, our patients quite often have to contend with other problems, which sadly are there. So there is a lot of ignorance about sickle cell disease and its symptoms and how severe that pain can be. And that ignorance is in the community, people out in the streets, but sadly that ignorance exists even in healthcare settings. Doctors and nurses may not know all they should know about sickle cell disease. And that ignorance often leads to disbelief. Patients are not believed when they talk about their pain. And when they are not believed, that ends with prejudice. And quite often our patients are seen as drug-seeking individuals. That is very sad. And we cannot forget that racism is still a problem, is still a big issue. And it is heartbreaking to know that quite often our patients around the world, I'm sure, end up in a healthcare setting when they are in pain, when they are feeling very vulnerable. And instead of finding comfort and understanding, what they find is prejudice and being treated as drug addicts. So bearing in mind all that perception of a patient, and consequently a doctor possibly, is completely understandable. You can understand why pain does predominate in one's thought. But just because something is understandable or justifiable doesn't necessarily make it 100% correct. Are there things that are missing when we have that approach? One, there can be that false sense of reassurance. As we said earlier, not everyone suffers of severe pain. There are many patients who hardly ever get pain, or patients who do get painful crises that have large gaps in between where they're free of pain. Does that mean that they are well, that there are no problems? It doesn't. However, that false sense of reassurance leads to quite significant issues. They may not be followed up appropriately. They might not come to hospital for their normal visits, for their follow-up appointments, for the regular reviews, simply because they're not in pain and they don't see the need to come to hospital. Closely related to that is that they may not comply with treatment. And that actually is a very common problem. If they're not in pain, they don't see why they should take tablets or any form of treatment. Specifically on this topic, there is a subgroup of patients with sickle cell disease. All our sickle cell patients are anemic by definition, but a subgroup are much more anemic than the others. And that subgroup quite often actually don't suffer of pain, or suffer of pain very little, but they are at a very high risk of developing kidney complications and pulmonary hypertension and stroke, so some serious complications. And those patients you want to treat, and you want to treat quite aggressively to prevent those from happening. And it's quite difficult to actually get patients to comply, because even though you can explain that they are at high risk of developing these very serious complications 5 years or 10 years from now, they feel well at that time, so they're not necessarily open to it. And having that sense that sickle is pain and pain is sickle quite often might lead to lack of awareness of the other complications. I have the very quote, priapism, what's that? I've heard that so many times from male patients who are in their 20s and 30s, and they don't even know what priapism is, which is something that can lead to significant disability. Yet they may know that because it's not about pain. And finally, that false sense of reassurance that if someone is not suffering of severe pain, it means that everything is okay, can have an impact on research, which we much need in sickle cell disease, and patients will just often not be willing to take part in any research because pain is not a serious problem for them. But most patients do suffer of pain, and that pain can be acute, in crisis, can be chronic pain, can be a bit of both, where they have chronic pain and then that gets accentuated during crisis. And for those patients who are the majority, quite often we can lose focus. And what I mean by that, so it has many aspects, if you like. What I call the quick fix problem. Quite often, our patients who have pain will expect some painkillers and nothing else. And of course, it's absolutely reasonable that when someone comes with acute pain, what they need is a strong painkiller. There's no question about it. But as we said earlier, the experience of pain is a multi-layered phenomenon. And quite often you need to address many things at the same time to address pain appropriately. And it's not just about a painkiller. The painkiller may be part of a whole host of interventions. Seeing a psychologist, participating in a sleep workshop, dealing with all the other socioeconomic issues that patients have. So they may not engage with all those interventions. What I call tunnel vision, and that affects both patients and doctors. So quite often when someone is in pain, they might find it difficult to comprehend why you're looking into other things. Why are you checking the protein in my urine? I'm in pain, I just told you. But of course you have to check the protein in the urine because that's how you can detect early signs of kidney disease. Why are you sending me for a scan of my liver or my heart? It's my arm that's hurting. And not having so not being open and understanding that other than pain, there are other things we need to be looking at. And that tunnel vision also affects the healthcare professionals. Quite often, the doctors themselves, when someone presents with pain, consider it a sickle painful crisis, not thinking necessarily that someone can have sickle cell disease, but can have also another condition that causes pain that coexists. And usually our patients can tell you if a pain they experience is their sickle pain or it's something else, but we don't necessarily listen. I have an example recently from a neighboring hospital where a patient presented with abdominal pain and he was saying, "This is not my sickle pain. This is not my sickle pain." And he was seen by a consultant, a senior a general medical doctor, not a hematologist. And it was all sort of considered to be a painful crisis. The patient actually had pancreatitis. But that was not thought of. He had sickle, he came with pain, it was bound to be sickle pain. And what's most ironic, the doctor who made that diagnosis was actually a gastroenterologist, yet he missed the pancreatitis. So we can lose focus, as I said. And then there is another risk, and that actually affects us, the doctors mostly, is that out of sight, out of mind attitude. So if a patient is not getting crisis, is not coming to hospital, we can in a way deviate and our thought might not focus on those patients as much as those who do come to hospital all the time, because the ones in hospital are in front of us, so we have to deal with them. And in a way, you neglect the patients who are not in so much pain. They don't come to hospital, yet they have the potential of developing other problems. And again, I'm going to talk about impact on research, because we really need research in sickle cell disease. Again, patients who do have pain will only take part, or often will only consider taking part, if they feel the research itself is going to help their pain, which of course is not the case, because research, when you do any clinical study, you don't know the outcome. But also what the clinical study may be may not be targeting the pain, may be targeting something else. So again, that has an impact on that. So having said all that, how should healthcare professionals, how should doctors, nurses, healthcare systems view sickle cell disease? What should they try to achieve? What should they offer to patients? And more importantly, how should patients see their own condition? And what should they expect of us? What should they demand of us? And I said earlier that it is a matter of perception sometimes. Well, I don't think it should be. It shouldn't be a matter of perception. I think the way to see the problem is actually the original slide I showed. It should be everything. Every problem has to be dealt with. You don't pick one over the other. If you put a fire alarm in your house, you don't pick your favorite room and install a smoke detector there. You protect your whole house. So equally, you have to deal with all the problems. You need to be aware of all the problems, first of all. And that is predominantly when it comes to patients, they need to be aware of all the problems, but doctors as well. You need to be aware of all the problems and deal with all the problems at the same time. I have everything scattered around, but pain is at the center. And that is not by chance. There is a reason. Pain is the most common problem of patients with sickle cell disease, is what disrupts their lives. And you have to treat that first. You have to treat that first. You have to treat it aggressively. I'm putting there the slide I showed you earlier. You have to make sure that you get on top of it, while at the same time fighting all the ignorance and prejudice that exists, and make that experience of the patients better. If I'm hit by a bus and I end up in hospital bleeding with my bones broken, of course I want you to make me stop bleeding and put my bones together. But first of all, what I want you to do is give me a good shot of morphine because I'm in agony, and then you fix me. But so the pain has to be at the center, but equally all other aspects have to be looked at, have to be monitored, have to be treated. When we talk about pain and aggressive management of pain, is about making our patients comfortable. That's the definition of palliation. In the 21st century, palliation is not good enough for sickle cell. We have new treatments coming out. We have treatments already. We have also new treatments coming out. In the 21st century, we need to be treating sickle cell disease with a view to make our patients live to a ripe old age, and also lead healthy lives, be in a good state when they reach that old age. And to do that, we have to be monitoring all the other problems, and often instituting measures earlier rather than later. And that is more or less what I had to say.
Thank you so much for that, Dr. Tsitsikas. Very, very informative. Yeah, I've learned so much today. It's actually good when you're seeing it on picture like that. I know there's so many comorbidities, but when you're seeing it like that, it actually does make sense. It makes so much sense that there's so many other aspects, and pain is just really, really highlighted. We have people who've joined us. Do you have any, there's no questions in the chat box. Before I ask any questions, does anyone have any questions, please? Just unmute yourself. Okay. Are you going to, did anybody want to say something? You go.
Yes. Sometimes when we present to hospital in pain, But let me say if it's not.
You're not very clear.
Ugo, you're
Would you
breaking up.
stop sharing screen, Dr. Tsitsikas? I'll try.
Hang on.
Let me try. I have to do that before I.
Yeah, hang on.
Okay,
Okay.
there we go. All right, go ahead, Hugo. Sorry, you were a bit unclear. Just speak closer to the microphone.
Okay, sorry, like what I was saying, when we present to the hospital in pain, some doctors and nurses, they don't believe us when we present to hospital in pain. So why is that? Why is it that they don't believe us when we present to hospital in pain?
So, as I said earlier, that is one of the issues we do have, and it is about education. It is about training people to explain how severe the pain of sickle cell disease can be. At the same time, it's not about always not believing. It is about trying to address problems in a more, how should I say, in a more comprehensive manner, so that we can improve someone's condition overall. But you're very right, and I said it in my talk earlier, that disbelief and ignorance that leads to disbelief, that leads to prejudice, is quite often the case, and that can only be solved by continuous education and training that we all have to be. By we, I mean people like myself looking after sickle cell disease need to be trying to educate others who actually are involved in the management of patients with sickle cell.
I think the problem mostly, what I've heard and what I've seen even here, is that the clinicians mostly in ED, I don't think they do sort of understand the severity of pain with people living with sickle cell disease. And I think that's where most of the time the misconceptions come about. So maybe that's what, you specialized doctors in the hospital should be doing, is to deliberate, just reinforce. I mean, learning about sickle cell, like our organization, we've done a course which is like 60 minutes long. It takes even few minutes than that for somebody who's been to uni to understand just how this issue is a major issue in the sickle cell community. So I think that's something that you clinicians who are actually trained in this and understand, even just putting up maybe posters in emergency departments to understand what people living with sickle cell disease go through.
You're quite right. That is what has to be happening. I can tell you in my trust it is happening. And constant education and training sessions with the emergency department and the general medical teams is very, very important. And I would go further. It's quite important to actually have that education and spreading the information out in the community, because I think our patients face quite a lot of prejudice in their own communities quite often, which of course doesn't make things any easier for them. So yes, I think education and awareness is a big issue still. I think it is getting better. I think it's better now than what it was, say, 10 years ago, but there's a long way to go. And it is about educating, explaining to healthcare professionals all the aspects of sickle cell, both in terms of how severe the pain can be, but as I said, more importantly, sometimes that it's not all about pain, because I'm very concerned that sometimes our patients do come with serious complications that can actually prove life-threatening, and they're just labeled as a painful crisis when it's a lot more than that. And at the same time, I think our patients do face quite often a lot of prejudice and stigma in their own communities, not by healthcare professionals anymore, but from people who know they have sickle cell, or who know that they have to use strong painkillers and so on.
I think I want you to touch back on the just the different types, the acute and chronic pain. I know maybe some of the people on this platform might know, but the majority of people people watch from different parts of the world. Would you just explain again the difference between the acute pain and the chronic pain and how you treat the two?
So acute pain is quite easy to comprehend. Acute pain means that suddenly you come up with severe pain. You get treated, you get painkillers, and within a few days, the pain has subsided. So in a way that is more easy to define. Chronic pain is a much more vague situation. Chronic just means that it's something that goes on for a very long time. Outside sickle cell disease, defining chronic pain is much easier. So, for example, if I fall from a ladder and I break my back, I have chronic pain in my back because of that injury, and that's that. But with sickle cell disease, chronic pain would just refer to pain that is there more or less consistently and doesn't have those fluctuations of a crisis. But it's quite difficult to be able to say whether that chronic pain is the same as if I had an accident that broke my back, or it is a constant sort of a constant state of minor crisis that fluctuate all the time, and that makes them be in pain continually. But ultimately, what chronic pain means is that is experiencing pain the majority of your time. And that has to be dealt in a different manner, because that has many layers, and that has to be approached. Painkillers is only one aspect of it, but then there are many other things that have to be considered. And these patients have to have access to specialist clinics where you have pain specialists involved as well. You have to see whether there are any anatomical reasons why they have chronic pain, if they have arthritis of different types. And as I said, you have to have more of a long-term plan when you talk about chronic pain. It cannot be just painkillers. Quite often you need to use painkillers. There's no question about it. But you find that with chronic pain, painkillers often don't work. Or they stop working after a while, and what we end up doing is increasing the doses, which is the only aspect of medicine where you do that, where you give a drug, it doesn't work, and all you do is actually give more of it. And you have to have and that's why I was talking about a holistic approach, because you may find that if it's a combination of drug therapy and psychology input and physiotherapy and sleep workshops, because as I said, sleep disturbance is a huge problem with our patients. And having that sort of long-term plan and a step-by-step process where you try to help with the pain, I have seen that work. And ultimately, quite often, we need to learn to live with a problem. And that is actually quite challenging, but sometimes that is the case.
Talking about the holistic approach in terms of, you spoke about knowing the underlying cause. Of course, if somebody has chronic pain, that's different. But if all of a sudden they have this acute pain, you spoke about having to actually understand the underlying cause of that pain. Again, this is me thinking as a healthcare professional. I don't treat people living with sickle cell disease. I'm a nurse, I'm in admin, but I'm just thinking, would you think something like flow plans to sort of just target if somebody comes in with acute pain, these are the possible things that you should be looking at? Because quite often I've seen, and even then, my daughter had the bone marrow transplant about over 24 months ago. So we went back in, she's still, recovering. We went back in, she had a bit of pneumonia. So we went in and the doctor, I think, didn't read correctly. I don't know, for whatever reason, she thought she still had sickle cell disease. So she came in panicking. No, we need to give pain medication. She's in pain. She's got sickle cell. I'm like, hang on, have you read her file? No, panicking, because for them, sickle cell is pain. So I had been actually, I had to cut the story short to explain to them what was the issue and what was happening. But I'm thinking, do you think like a flow chart would be able to be very helpful in terms of having that holistic approach to say, if somebody comes in with chronic acute pain, these are the possible triggers. You look at this, you look at that. Of course, treat, as you said, if you go in, if you've got an accident, they'll first give you a sort of morphine to make you comfortable. But they need to understand the underlying cause rather than just giving pain meds. I know a lot of people right now, as I speak, I know somebody who's in hospital, and that's what they do. They try, morphine, they try dilaudid, they try that until they sort of fix the pain. But we need to know exactly what's causing that pain. Do you think that approach can help, or is it happening?
Of course it can help, and of course it is happening, and obviously different places have different practices. So first of all, we have to bear in mind that actually a patient with sickle cell disease presenting with pain to the emergency department, most of the times it will actually be sickle related pain, a painful sickle crisis, and you do need to treat that very aggressively and very fast to get on top of that pain. But explaining to other sort of medical specialities, it is going back to what we were talking about earlier about education and training. So delivering training sessions to non-sickle specialists, let's put it that way, and explaining all the other complications that come around sickle cell disease, that just because someone is coming with pain doesn't mean that that's the end of it. It can be pain because of something else, or it can be a sickle painful crisis, but at the same time something else is happening. So for example, a very common trigger for a painful crisis is infection. It's very important not to miss that, because our patients can get very ill with infections. So even though patients will present not with the symptoms of the infection, but with pain, it's very important for the doctors receiving them to actually look actively whether there was an infection triggering that crisis and treat that infection as well. So that is part of education and training, which we are all trying to deliver to our non-specialist colleagues.
Yeah. Does anybody else have any questions? I'm asking too many questions. Deborah, do you have anything to say?
I just want to thank you, the doctor. I've learned a lot about my illness. This has opened my eyes on how I should view my treatment, because mostly doctors just treat our pain but do not look into other complications that are caused by sickle cell. And for me, I always have to inquire with the doctors to do more tests so that they can get to the bottom of my pain. So I've learned a lot from the doctor. Thank you so much.
It's a pleasure.
Thank you, Deborah.
Hi, everybody. My name's Oleander. I thank you, Dr. Dimitri. Lovely to see you on the platform.
Lovely to see you.
And Agnes as well. I just wanted to make, I don't know if, so firstly, I'm sorry I was a little bit late. I don't know if I missed this or not, but in terms of pain, one of the points that many of our members of our support group mention is that quite often when they are in pain, they have techniques which actually helps them deal with the pain. So at first glance, perhaps some of the healthcare professionals may look at them and think, well, actually, you don't look like you're in pain. But I don't know how to tackle that and how we deal with that, because many people say the same thing. My son himself, he's now 16, and he's now learning about how to deal with the pain. It's not that he doesn't have the pain, it's just that he knows he has techniques that he uses to sort of distract himself, like, well, playing games on his tablet. And so sometimes healthcare professionals have made comments. I'm not necessarily talking about a particular hospital. It's just what I've heard from various sickle cell patients. How do we actually cope or deal with that situation?
So Oleander, that's an excellent point. I have so many experiences, so many stories to say exactly on that. And I think it's a worldwide phenomenon. It's not which hospital or anything. I think that is a problem that sickle patients face worldwide. it is that disbelief. As a senior trainee many years ago, I remember going around with my consultant, who was a hematologist, and I remember seeing a sickle patient who was in severe pain, and she was lying frozen in bed because she was in agony. And my consultant, my boss, essentially told the patient to stop acting like a dying swan and come on, get up and, live with it. Then we move to the next bay where there is another sickle patient, and he's not there because he's gone down for a smoke. And my consultant's reaction was, oh, so that's so much, so he's got so much pain that he can go down for a smoke. So essentially he doesn't have pain if he can go down for a smoke. And I remember that time I stopped her because I was quite senior by that time. I knew what I was about to do. It was just before I got my current job. And I said, hang on, you cannot have it both ways. Which one is it? Is it the patient who is lying in agony doing the right thing? Or is it the guy who went down for a smoke because he came with pain, he got some pain relief, he felt a bit better, he does his own thing. More recently, I heard of a nurse questioning a patient's pain because she saw the patient having a cup of tea.
Wow.
It is insane. It is insane. It is heartbreaking. It makes you laugh. It makes you cry. It is awful, but it is real. And I know that this is a problem patients with sickle cell face worldwide. It's not here or there or anywhere. And other than education, whatever that means, whether it is doctors giving education sessions, patient groups, talking of patient groups, your patient group, I think, is doing a brilliant job in educating. And I think there is more scope for patient groups actually reaching out to healthcare professionals. So it is education at all different levels, doctors, nurses, and so on, and campaigning. Talking about what you just said, quite often I can see that patients will try to look in pain because they know they will not be believed otherwise. Of course, they don't have to do that. They don't have.
Yeah.
They should have to put an act. They should just say, "I am in pain." But yeah.
I've heard terrible stories from places like Nigeria where people, just even the way they dress, the way you dress when you're going to hospital affects how you're going to be treated. So it's actually, it's really, really bad. But I guess, partnerships, having this holistic approach, collaborations between patients, doctors, and other physicians, other allied health staff as well.
I think patient sort of driven initiatives are the most effective. Leander knows that. We recently had with COVID-19, we had a huge issue about the uptake of the vaccine, of the vaccination program by our patients. And then it was our patients themselves who campaigned for the vaccine. And I can tell you that now we have amazing uptake of the vaccine within our patient population. And that was the result of the patients campaigning for it. So that those empowering the patients and listening to patients and having patient champions for different causes is actually something that really works.
Well, thank you so much for that. Time goes so fast. We have a minute to go, but I'm glad this is recorded, and you can come back for part 2 if you've got many questions. I like hopefully finishing on time. I'll just get last 1-2 questions before you go. Where do you see sickle cell disease in the next 5-10 years?
Oh, it's very exciting. I think there is a lot of optimism. There are many new therapies coming out, and I can see sickle cell being treated with different combinations of drugs that attack the sickling process. Is a very complex one. We all know about the misshapen red cell blocking the blood vessels and so on. But actually, even though that is the initial triggering event, that leads to a series of problems subsequently. So the sickling process is a very complex one. And we are developing treatments that attack the sickling process from different angles. And there are more drugs coming out. So I can see sickle cell being treated. And I think we all mature as a society, the doctors, the patients, and the society itself, to appreciate that it's not just about treating pain, but it is about treating this disease with a view to make our patients live, as I said, long and healthy lives. And I think we will be able to do that. Of course, we have the prospect of the curative treatments, like your daughter got a transplant, but we have to still bear in mind that probably that will not be feasible for the majority of our patients. So even though it's great to know that there is the prospect of curative treatments with transplantation and gene therapy, I think the vast majority of patients will still need pharmacotherapy drugs. But I think we will have more and more in years to come. We already have new drugs, and I think what we will be able to do is combining drugs that attack the sickling process from different angles.
Mm-hmm. I think that with this, like us, Oleander, Hugo, and others, us talking, Deborah, talking about, I've seen in recent years, I think also like social media has really helped, where people are comfortable to talk about it. There's groups where people are asking questions, within the palm of your hand, you're miles away, you can talk and just find solutions. Even though it's sometimes, I think yesterday I was discussing that it can be a catch-22. If you're in a less resourced country, you have these groups and there's so much discussions going on how this other part of the world, they can access this medication and you can't. But, it's just a fact of life and how we need to close that gap between less resourced countries and developed countries.
Quite. And of course, we have to think that when we talk about sickle cell disease, the sickle cell disease in London or Australia and so on, or the US, is a very, very small proportion of sickle cell disease worldwide. As you say, the vast majority of patients with sickle cell disease live in Africa, live in countries that may not necessarily have the resources to treat sickle cell disease at the same level, and that has to be addressed.
Well, thank you so much.